Hello, everyone, and thank you so much for being here today. My name is Charles Cordova, and I'm an economist with the New Mexico Workers' Compensation Administration. It's my pleasure to share with you our proposal for updating the medical fee schedule calculation methodology. This presentation is an in-depth follow-up to the 10-minute presentation we gave during the fee schedule meeting last year. We're looking to transition to a system based on the Resource-Based Relative Value Scale, or RBRVS, which aims to provide a more efficient and transparent way to determine reimbursement rates for healthcare providers in the workers' compensation system. During last year's fee schedule presentation, I provided a quick overview of the rationale for switching to RBRVS and shared our proposed conversion factors and some initial statistics on the potential impact. I also mentioned that I'd be back with a more in-depth presentation to delve into the specifics of the model I developed for calculating the new conversion factors and to address any concerns that were raised. Well, here we are today, and I'm excited to share this more comprehensive presentation with you. Please note that some of the material in this presentation is quite technical. As I mentioned during the fee schedule meeting, this is an optional presentation that was intended to be an in-depth and technical look at the proposed RBRVS methodology, and I'm giving this based on expressed interest during the fee schedule meeting. We'll begin today with some background information on RBRVS and why we believe it's the right direction for us. This may be a refresher for some, but it's important to establish a solid foundation. After that, I'll dive deep into the mathematical model that we use to calculate the conversion factors, followed by a discussion of the results of the model. Lastly, I'll share the methodology I've developed for conducting annual fee schedule updates under the RBRVS system. Once again, thank you for joining me today, and I look forward to productive and engaging discussion. To begin with, let's take a closer look at our current fee schedule calculation methodology, which has been in place since the 2017 fee schedule was implemented. We start the process by gathering fee schedules from 7 nearby states: Arizona, Colorado, Kansas, Nevada, Oklahoma, Texas, and Utah. We also purchased a CPT code list from a third-party vendor that determines which codes will be included in the fee schedule for the year. Next, we compare each code contained in the CPT code list to the fee schedules from nearby states. If at least 4 of the nearby states have set a maximum allowable rate for a given code, then we calculate the 60th and 80th percentile of rates for nearby states. If New Mexico had a rate for a given code last year, and the rate is smaller than the 60th percentile, or larger than the 80th percentile, we adjust it to the 60th or 80th percentile accordingly. If it's within those ranges, we leave it unchanged. If the code is a new code that had at least 4 nearby states' maximum allowable rates associated with it, then we set it to the 60th percentile. And if the code does not have at least 4 rates from nearby states, the code is reimbursed by report. So why are we looking into changing this methodology? Since its implementation, we've observed that the current fee schedule methodology has some areas that could benefit from improvement. First, our current fee schedule methodology is influenced by the rates set by other states. Consequently, changes in other states' fee schedules can directly impact our rates. For instance, if a neighboring state decides to increase rates due to insufficient provider participation in a specific service family, New Mexico's rates will be affected, even if our provider participation is adequate for that category. Conversely, if New Mexico identifies a need for rate adjustments in a particular service family, we're unable to make any changes to that family because we have to base our rates on the other nearby states' rates. By service families, I'm referring to CPT code categories such as surgery, radiology, or evaluation and management. Additionally, we've noticed that our rates in comparison to cost baselines are inconsistent across various service families. Generally speaking, prices can be compared with other major healthcare payers, such as group health organizations utilizing fee-for-service or Medicare and Medicaid. While we don't have enough data to compare with group health costs, an examination of our current fee schedule against CMS cost baselines reveals that reimbursements for different codes are unequal as compared to each other. This discrepancy may inadvertently create financial incentives to use certain CPT codes based on reasons other than patient need. Lastly, our current fee schedule methodology isn't very agile in responding to market changes. For example, the American Medical Association increased the relative value units for numerous evaluation and management codes a couple of years ago. This change was prompted by the high administrative burden on physicians due to the outdated RVUs. As nearby states updated their fee schedules, New Mexico's rates were only impacted by those that had already made updates by the time we implemented the fee schedule changes for the year. The lag also causes our state to trail behind others, and we only experience the full effect of changes after all neighboring states have updated their fee schedules. In sum, the current fee schedule methodology has some shortcomings that we believe need addressing. These include its reliance on other states' fee schedules, inconsistencies in rates compared to cost baselines, and slow adaptation to market changes. As a solution to the issues we discussed with the current methodology, we examined a different process that we think has the potential to improve our healthcare landscape: the Resource-Based Relative Value Scale, or RBRVS. This system is widely adopted by the Centers for Medicare and Medicaid Services to set the maximum allowable rates for services covered by Medicaid and Medicare. RBRVS works by establishing a schedule of multipliers called relative value units. These multipliers take into account the work, malpractice, and facility expenses generated by the provision of various medical services. To determine the maximum allowable rate, each service's RVU is multiplied by a dollar rate known as a conversion factor. There are several key advantages to adopting the RBRVS system. First, it allows for easy adjustment of conversion factors to account for local market conditions, such as low provider participation or medical inflation. Unlike our current methodology, RBRVS is not influenced by changes in other states' fee schedules, ensuring that reimbursements are more equitable and reflective of our unique needs. Moreover, RBRVS has a proven track record of success, as it's been implemented in 34 out of 44 NCCI states and the District of Columbia. In fact, over 75% of all non-Medicare payers use an RBRVS-based model to establish fees or maximum allowable rates for services. By adopting the RBRVS system, we can benefit from its established efficiency and equity, allowing us to create a more reliable and fair payment structure in our healthcare system. In case you're interested, I've included a map of state adoption of RBRVS over the country. The red in this map represents at least some RBRVS basis and fee schedule states. Blue is other methodologies, generally a usual, customary, and reasonable basis, and orange represents states with no fee schedules. I put this together about a year ago, so it might be a little bit out of date, but it should be mostly accurate. I understand that one concern about RBRVS is that it's based on Medicare rates, which are much lower than comp rates. I want to assure you that we're not planning to tether our rates to Medicare in adoption of the RBRVS system. In the RBRVS methodology, rates are determined by combining a relative value unit, or an RVU, which represents the cost of a service relative to other services, with a conversion factor. This conversion factor is a dollar amount set by CMS to maintain their own budget neutrality. It's important to note that Medicare's budget neutrality is not relevant to our rates in New Mexico. Our intention is to utilize the RVU portion of the Medicare system while setting our own conversion factors to establish rates that are suitable for New Mexico workers' compensation. We will not be using or considering the Medicare conversion factor in our model. By adopting this approach, we can ensure that the rates we set are both fair and reflective of the specific needs and conditions within New Mexico. In the next section of the presentation, we're going to talk about how we actually determine the new conversion factors for the RBRVS system. Although the WCA's main task was to determine conversion factors, the process of setting them was not straightforward. There's a notable variation in effective conversion factors for individual CPT codes when using the current New Mexico maximum allowable rates. In simpler terms, the relationship between the current rates and the corresponding relative value multipliers for each CPT code unveils the effective conversion factor applicable for each rate under the RBRVS system. Comparing these effective conversion factors exposes significant disparities, even within the same service families. Additionally, not all CPT codes have the same utilization. Each year, one specific code is responsible for roughly 12% of all expenses from physician services in our system, while numerous others are not used at all. The interplay between payment share and effective conversion factor variance is vital in determining the influence of a given conversion factor on the total costs of physician services. Due to the intricate nature of these interactions, minor changes in conversion factors can result in substantial shifts in overall market expenses. To illustrate, if, hypothetically, the current effective conversion factor for the 12% code was $57, and we implemented a new conversion factor of $62 for that code, this small change alone would cause a 1% increase in total physician services costs from the impact of a single code. And that's just one code out of around 10,000 codes, without considering the impact of all of them together. This example highlights the potential for significant changes if conversion factors were improperly applied. It was essential for us to establish a fee schedule methodology that wouldn't cause unnecessary disruptions in the workers' compensation marketplace. My aim was to calculate conversion factors that would have minimal impact on the change in total systemic costs for physician services. The goal was to identify a set of conversion factors that would result in the sum of cost increases and decreases across all CPT codes being as close to zero as possible. Initially, I believed I could achieve this using stochastic analysis, or more simply, calculating the expected impact on costs that every possible conversion factor within a reasonable range would have on costs, then picking the one closest to zero. However, with nearly 10,000 separate CPT codes and conversion factor units measured in pennies, this ended up being unrealistic. Estimating the impact of a reasonable range of possible conversion factors would have required over 100 million calculations. After it became clear that attempting a single calculation scenario was going to take my computer hours of calculations, I decided that a less CPU-intensive method was needed. The Monte Carlo method is a mathematical technique, or when applied, a mathematical model that uses random numbers to find precise solutions to problems that require a lot of computational resources. Instead of calculating every potential outcome for a specific problem, it computes the outcomes of a smaller number of random points within a given range, then tells you which random outcome in your range is the closest to a particular target. In the case of identifying conversion factors, the target is a zero for the sum of changes and costs resulting from physician services, and each random conversion factor is what we refer to as an iteration. For each iteration, we calculate the impact on costs that implementing the conversion factor would have. In our model, we used 100 random iterations, then selected the conversion factor with the lowest change in medical costs, as well as the next lowest and the next highest. We then made a new range of conversion factors between the next lowest and next highest. Finally, we reran the model over and over again, narrowing the band each time until we found the conversion factor with the lowest change in costs resulting from physician services to the nearest cent. To implement our model, we depended on 4 sources of data. First, we have the list of maximum allowable rates calculated using our existing methodology. Second, we have the payment share for each CPT code. We gather commercial insurer data from NCCI and obtain experience data from several TPAs to represent our self-insurance data. We then weigh the commercial and self-insurance data according to their respective market shares, as outlined in our annual expenditure report, before integrating them into the model. We obtained our RVUs from the AMA and supplemented them with gap fill data from a third-party vendor. Finally, the service categories adhere to AMA guidelines, with a few exceptions made for recategorizing certain codes related to psychology and psychiatry. I'll elaborate on that later in the presentation. This chart shows a simplified example of how I calculated conversion factors that minimally impact the cost of physician services. In this case, we look at 8 surgery CPT codes and calculate the cost change for physician services when using a random conversion factor, $75.62 in this instance. For simplicity, we assume that these 8 codes are the only 8 codes in existence for this hypothetical scenario. The model estimates the cost change for each CPT code when using the random conversion factor. Keep in mind that the maximum allowable rate is the RVU multiplied by the conversion factor. For example, for CPT code 29827 on this list, multiplying the RVU of 31.54 by the random conversion factor of $75.62 gives a maximum rate of $2,385.05. The model then calculates the difference between the new rate and the old rate as a percentage, representing the increase and decrease or decrease for that code with the random conversion factor. Please note that this includes the chance that some codes, like 69826 in this instance, can change by quite a bit, but in others there's very little change. After calculating the change in MARs, the model multiplies the percentage change for each code by its utilization, giving more importance to codes that are frequently used, and less to those with a small market impact. Since all codes are weighted by utilization, the sum of the final product shows the total estimated change in costs resulting from physician services for the entire market when using the random conversion factor. In this example, the estimated total change in physician services costs is a reduction of 1.24%. This calculation is one iteration in a Monte Carlo scenario. In this slide, I'm displaying 6 Monte Carlo iterations. As you can see, iteration 1 is the iteration we examined in the previous slide. For each iteration, the model calculates the total change in cost resulting from physician services. Based on these 6 iterations, a conversion factor of $80.50 would result in our target, which is no change to costs resulting from physician services. I included the conversion factor we were looking for here just for demonstration purposes in this hypothetical scenario. In the actual model, it takes quite a few iterations to find the target. The WCA employed this model to calculate conversion factors for 6 service categories: surgery, pathology and laboratory, medicine, radiology, evaluation and management, and psychology and psychiatry. For each category, we ran 100 iterations with a broad conversion factor range from $20 to $150 as the random variable. After gathering the results, we narrowed the range for the 100 iterations and reran the data. This process was repeated until we identified the single conversion factor that most closely approached zero market change down to the penny. I'm going to briefly show you the actual model we used. It's quite a bit more complicated than the simplified method, but all of the same basic principles apply. As you can see, in the lower left hand here, we have all of our experience data, including commercial and self-experience data gathered from TPAs. We have the respective market shares for commercial and self-insurance, as outlined in our annual expenditure report. This category here has our CPT code data with the service family, the CPT code, and a description of the codes so that we can look up any individual codes later. This line represents the relative value units for each code. And this line here represents last year's maximum allowable rate. Finally, this line is showing us the calculated new rate using the market minimizing conversion factor that's identified in the model. Everything over here is the actual iteration scenarios themselves. These top categories here are the random numbers that are put in. And down here, this formula looks up the service family and then utilizes the random variable put into this line for that service family to categorize the change in markets cost resulting from physicians' services impact of that code after weighting by its utilization. And so I just want to show you how it works real quickly. All of these other categories down here is statistics on the total market impact of each random iteration. And then we have some data showing the rankings for each of the different lowest, next lowest, and next highest codes as we discussed earlier. So here's the $1 to $150 range. And what it's saying is that at this range, the conversion factor that's closest to market minimizing is $77.72, with $77.03 being the next lowest below it. So I'm going to change the bottom band here to 77.03. Fill that through to the right, so we have a smaller band. And now we have some new data where we can see that the next highest now is going to be $78.78. And then we just keep repeating that process until eventually we identify the market minimizing conversion factor for each service family. Now that we've reviewed the methodology we use to determine the new conversion factors, I'm going to go over the results of the model with you. Please note that these are for last year's fee schedule, as we don't yet have enough data to fully calculate this year's fee schedule and run analysis on it. As you can see, the calculated conversion factors were $77.64 for surgery, $74.03 for pathology and laboratory, $59.88 for medicine, $108.57 for radiology, and $56.58 for evaluation and management. In this slide, we now have a separate conversion factor for psychology and psychiatry. As you may recall, at the fee schedule meeting, we had multiple comments about provider shortages in psychiatry and psychology, and it was recommended that we should look into separating it out as a category. We followed up with our own internal research into the status of behavioral health professionals. While we didn't have sufficient data to conclude that there's a shortage in workers' compensation specifically, we were able to confirm that there is a significant behavioral health professional shortage in New Mexico more generally. Further, if we were to keep the behavioral health CPT codes rolled up into the rest of medicine, it would result in a net reduction in medical costs for those codes. Finally, pulling them out had a fairly minimal impact on the overall medicine conversion factor. Based on those facts, we determined that there was sufficient cause to run a scenario separating psychology and psychiatry as an individual conversion factor, both to maintain those CPT code rates and to allow for an easier potential to make adjustments if needed later down the line. This slide shows the resulting change in medicine and the addition of psychology and psychiatry. According to NMSA 1978, the rates in the schedules of maximum charges shall not fall below the 60th percentile or above the 80th percentile of current rates for healthcare providers. In determining current rates for healthcare providers, the director shall utilize a variety of healthcare provider charges, including the charges of those providers serving low-income, Medicare, and Medicaid patients. Because the statute specifies that the rates must fall between the 60th and 80th percentile of current rates for healthcare providers, we had to make sure that the model estimated conversion factors did not go outside of the given percentile ranges. In order to calculate percentile ranges for the conversion factors, I first calculated the effective conversion factors for all CPT codes for each of the 7 nearby states. Then, for each individual CPT code that had 4 or more MARs from other states, I calculated the 60th and 80th percentile effective conversion factor for those codes. Next, for each code with 4 or more rates, I weighted the 60th and 80th percentile effective conversion factor for those codes by their shares of physician payments. Finally, I took the sum of the weighted conversion factors for each category to develop weighted 60th and 80th percentile conversion factor ranges. The chart here shows the results. As it turned out, all our calculated conversion factors were within the calculated percentile ranges, so no changes to the conversion factors were required. This chart shows some statistics to give you a better idea of the actual impact implementing these conversion factors would have on maximum allowable rates. The column with all of the zeros indicates that our model has calculated no change to physician services cost for each service category rounded to the nearest 0.1%. For the final two columns is context. When we implement the conversion factors, some codes go up and others go down. These statistics relate to the amount by which the codes went up and down in aggregate. We're looking at all of the CPT code changes in absolute terms here, so it ignores whether or not each code went up or down and only looks at the amount by which they changed. As we discussed, our model is designed to estimate the conversion factors that result in no change in costs resulting from physician services and attempts to set them to zero. NCCI also has a model that makes those estimates, but it does it a little differently, and it's the source we use when we get the numbers we show you each year at the medical fee schedule meeting. Last year, we generated a sample fee schedule using the conversion factors that we have been discussing and sent it to NCCI along with our actual fee schedule to have them compared side by side. These charts show the results of that analysis. Please note that there are minor differences between the two methodologies. This is due in part due to differences between the way our model calculates cost neutrality and the way that NCCI's model does. Part of that is that we include self-insurance data, whereas NCCI is only looking at carrier data. Additionally, there are some differences in the way the categories sum up the estimated impact of each additional code on physician services. And also, NCCI has an other category that contains some data we don't receive from them, and that affects the relative percentages of the service families in their analysis, but mostly to a negligible degree. That said, the key takeaway on this chart is that the total shows that NCCI predicts an increase of 0.7% in physician services costs for the current methodology and a 0.9% increase if we switch to RBRVS this year. And this data comes directly from them, not from us, so this is an outside confirmation that our model works. This is a drill down of the previous slide showing the individual service families that make up the comparison. I'm not going to go too in-depth on it, but if you're interested in seeing how close our model got categorically according to NCCI, the data is here. Once again, all these numbers are directly from NCCI. As a note, NCCI does not separate psychology and psychiatry in their model, so there's not a category for that here. They're just included in medicine, and the fee schedule we sent them did not have these codes separated, as this had happened before we made that change. Also, I could have made conversion factors that matched exactly with the old fee schedule by service family according to NCCI estimates, but as I mentioned, there are differences in our models, and a large part of that is the inclusion of self-insurance experience data, so the numbers are different by choice. You might remember this chart from our short presentation previously. This line graph shows the historical impact of the annual fee schedule updates, plus the comparative impact of the two methodologies for 2023. The blue line here is the impact of the RBRVS sample schedule. The orange line is the actual fee schedule impacts for each year. As you can see, the difference of 0.2% between the two methodologies is negligible when compared to the impact that just updating the fee schedule has each year under the current methodology. Up to this point in the presentation, we've discussed the implementation of our model to transition to RBRVS. In the following section of the presentation, we're going to discuss our methodology for updating the conversion factors moving forward once we've transitioned. That said, before going into that, I'd like to discuss challenges and recommendations regarding the New Mexico fee schedule statute. As we discussed previously, the statute requires that rates in the schedules and maximum charges do not fall below the 60th percentile or above the 80th percentile of current rates for healthcare providers. However, the statute is not specific about which healthcare provider charges to use and how to use them, leading to ambiguity and difficulty in implementing what is a seemingly simple calculation. The current workers' compensation statutes allow the director to collect reports from self-insurers and insurance carriers, which pertain specifically to the workers' compensation system, and exclude other payer-type data, such as group health, Medicare, and Medicaid. If the WCA were to use the collected carrier-reported billing data to calculate the 60th and 80th percentiles, then the range of payments for which those percentiles were calculated would max out at the existing fee schedule maximum allowable rate. This would create a cyclical reduction in the maximum allowable rates, causing each year's reimbursements for services to drop to the old 80th percentile, which would become the new maximum rate, and a new 80th percentile would be defined below that rate. The consequences of this approach would be unsustainable and would absolutely lead to a significant crisis in the workers' compensation system within a short period of time. In addition to the difficulties related to using carrier data to meet statutory percentile requirements, there are also issues around using healthcare provider data. There is no statutory requirement for non-workers' compensation healthcare provider billing data to be provided to the WCA, and as a result, obtaining a representative sample of group healthcare provider charge data, regardless of payer type, is prohibitively difficult. While this difficulty could potentially be circumvented by accessing data from Synchronous, the New Mexico Health Insurance Information Exchange, Synchronous data is protected by HIPAA regulations that require a statutory carve-out in order for the NMWCA to gain access. The existing statute does not provide that carve-out. Alternatively, we've looked at getting group health data from data brokers. However, it's been prohibitively expensive, and we have not been provided with a budget for it. To overcome these challenges, the WCA has been using the previously described methodology based on nearby states' rates. Because nearby states' charges are applied to the providers in those states, and those providers serve low-income Medicare and Medicaid patients, this methodology is in line with the statute as written. However, this methodology has introduced issues related to fee schedule growth over time, particularly related to Nevada's use of relative values for physicians instead of RBRVS. As a result, some of the New Mexico's rates are very high compared to the rest of the nation, while others have lagged what they would have been had they been properly adjusted for medical price inflation. Finally, nearby states sometimes change their rates arbitrarily or in response to market and legislative factors that are irrelevant to New Mexico. Due to the issues mentioned earlier, the Economic Research and Policy Bureau recommends updating the fee schedule statute. As it's currently written, even after adopting the RBRVS system, the WCA will still be required to calculate the 60th and 80th percentile effective conversion factors annually and tie our conversion factors to those bands. While this didn't impact us this year, the calculated conversion factors are, in some cases, nearing these limits. If this happens in the future, whether the factors are pulled down or pushed up, the outcome would be conversion factors that don't accurately represent medical price inflation and real reimbursement rates. They would instead continue to be distorted by the unrepresentative actions of nearby states. While we can still enjoy many of the benefits of the RBRVS system under the current statute, a statute change would be necessary to fully reap all of the advantages. The WCA's mission is to ensure quick and efficient delivery of benefits to injured workers while maintaining a reasonable cost for employers. Annual updates of the provider's fee schedule play an important role in compensating medical providers in a manner that balances these objectives as we seek to find the right fee schedule level that balances provider participation with cost control. In order to make fee schedule updates, we begin with the assumption that the current fee schedule has struck that right balance and is at an appropriate level of reimbursement. With that in mind, to maintain doctors' real reimbursement rates over time, it's necessary to adjust the annual maximum allowable rates for inflation using a suitable inflation index. A 2017 study by the National Council on Compensation Insurance found that the CMS chain-weighted personal health care index is the best measure of medical price inflation for the workers' compensation system. This index includes components from both the Consumer Price Index and Producer Price Index and closely mirrors the services provided by workers' compensation. NCCI endorses the chain-weighted personal healthcare index as the ideal metric for this methodology. However, the index has a significant limitation. Its most recent published data at any given point in time is 2 years old. To address this issue, the WCA tested potential alternate deflators that could be used as a proxy for the index in annual updates. We evaluated the historical mean absolute error between 5 potential alternate deflators and the actual chain-weighted personal healthcare deflator index values from 2011 to 2020. After examining the results, the Federal Reserve Economic Data, or FRED's chain-weighted personal consumption expenditures for healthcare services index had the lowest mean absolute error of only 0.19% over the 10-year period. The sum of the reported inflations between the two indexes showed an aggregate 10-year error of 0.5%, which was negligible considering the total inflation over that time period. Consequently, we selected the FRED deflator as the best choice alternate deflator for this methodology. CMS adjusts its conversion factors annually using a complex formula that accounts for the Medicare Economic Index, update adjustment factor, legislative change, and budget neutrality. Federal law requires that changes to the Medicare physician fee schedule cannot affect annual CMS expenditures by more than $20 million without triggering budget neutrality adjustments. While parts of the CMS formula for updates are worth considering, such as adjusting for RVU growth and changes in medical utilization, others such as budget neutrality and federal legislative change are not relevant to the New Mexico system. Further, we cannot address inflation simply by adjusting the conversion factors by the chain-weighted price index each year, as the impact on physicians' real reimbursements would not equal the amount of the conversion factor adjustment. This discrepancy is due to changes in total annual RVUs and CPT code utilization. To maintain current real reimbursement rates without impacting total systemic costs, we developed a mathematical model that identifies new annual conversion factors, ensuring the expected impact on physicians' real reimbursements for each service category equals the chain-weighted price index. This model allows for isolated price inflation adjustments without forcing system costs to behave in unpredictable ways. I'm not going to go into the specifics of the model because it uses fundamentally the same principles as we used for conversion factor calculation, except rather than setting the conversion factors to target no change in costs, we set them to increase by percentage that results in the inflation target. As I mentioned before, NCCI sends us an analysis each year of the estimated impact of the new fee schedule on workers' compensation costs, particularly those related to physician services. I developed a mathematical model that closely mirrors NCCI's methodology, with predictions that come within 0.1% of NCCI's final number for every year I tested it, going back to 2015. In order to test the new inflation adjustment methodology, we applied the conversion factor calculation model we discussed in the first part of this presentation to historical data in order to develop a set of conversion factors that would have minimized the change in physician costs had we made the switch back in 2015. I went back and actually used all of the old data that we had saved from the 2015 fee schedule calculation, then built the model using that data to generate an entire fee schedule for that year. Then I used this inflation adjustment method to adjust those conversion factors to the deflator for each year through 2022. The examination of these updates revealed that both the new proposed methodology and the current fee schedule calculation process perform similarly in the long term in aggregate, but the new method is more stable in the short term. As you can see, the cumulative impact of costs resulting from physician services is only about 0.5% difference over the 7-year period. Considering that the current methodology varies by about 4% in some years, the aggregate difference is negligible. The old methodology shows large swings in costs year over year and is slow to react to changes like rising inflation. Based on these findings, we concluded that the new methodology offers the significant benefits to the New Mexico workers' compensation system that we're seeking without causing undue negative impacts. With greater stability and adaptability, the new method is a superior choice for managing workers' compensation costs associated with physician services. Thank you for your time today and the opportunity to present my research to you. I hope this presentation was informative on the RBRVS system and the approach that we've taken to determining a path for switching to an RBRVS-based fee schedule methodology. I've included my contact information on this final slide. Please feel free to contact me by phone or by email with any questions you may have, and I'll do my best to answer them.